Hi, everybody, and welcome to the Cases podcast series presented through Primary Care Sheffield. I'm Dr. Jim Lee, a GP in Sheffield, and I work as a peer review GP for cases in gastroenterology. And it's my pleasure to be joined today by Dr. Kumar Basu, who's one of our local expert consultant gastroenterologists. And Kumar's going to be talking to us today about reflux and dyspepsia. Thanks for joining us, Kumar. Could you maybe tell us a little bit about yourself, and then we can get started?
Yeah, thanks, Jim. Yes, I'm Kumar Basu. I've been a consultant gastroenterologist in Sheffield for 24 years now. I have a particular interest in upper GI gastroenterology and did some research into ablation of Barrett's esophagus. And I'm also involved in promoting guidelines for eosinophilic esophagitis and reflux. I do have an interest as well in the primary care, secondary care interface and education. So I'm very happy to be presenting this sort of podcast on a number of upper GI subjects for your education.
Thanks. Right, so you were going to start with dyspepsia, is that right?
Yes, so I'll talk about dyspepsia, which is a sort of very broad term derived from both Greek and Latin, meaning sort of bad indigestion, really. It's a complex of upper GI symptoms, typically present for 4 weeks or more. It can include upper abdominal discomfort or pain, heartburn, reflux, nausea, vomiting, fullness. If heartburn and acid reflux symptoms predominate, then that's very suggestive of gastroesophageal reflux. And these are very common symptoms and reasons for consulting in primary care, with up to 5% of attendances at your practice. Now, unfortunately, you can see these symptoms can be pretty vague and can be quite a poor predictor for significant disease. So what I'd like to do next is just talk a bit about sort of assessment, really, what you do in your surgeries. So perhaps the first thing to do is to assess for alarm or red flag symptoms, dysphagia, weight loss, symptoms suggestive of GI bleeding are all sort of red flag 2-week wait referral indicators. Cough and hoarse voice is also mentioned in the NICE guidelines, but I would suggest that a chest X-ray and a smoking history might be more important first there.
Yeah.
In terms of investigations, epigastric mass, supraclavicular nodes are obviously red flags too. The differential diagnosis is pretty wide. It's worth considering biliary or pancreatic causes, particularly if right upper quadrant or localized pain is more predominant, or a colicky pain. And of course, if there's things like disturbed LFTs, jaundice, stool color change. And don't forget, some people present with chest pain who on eating big meals, who may actually have angina. Ask about exertion. That's quite important in a risk group. But the commonest diagnoses will be functional dyspepsia, or another name for it, non-ulcer dyspepsia, reflux, of course, gastritis, and peptic ulcer disease. And, you know, important features to both manage and assess these conditions is to assess the lifestyle, you know, looking at smoking history, obesity, eating habits, triggering foods, alcohol, exercise, and sleeping habits. And also to assess the medications the patient's on, you know, to assess what antacids have been tried, over-the-counter PPIs, and also what provoking medications they may have, non-steroidals, anticholinergics, bisphosphonates more and more, calcium channel blockers, nitrates, tetracycline. All these things can cause esophageal or gastric symptoms. And of course, something that we do too little and too late often is to assess for stress, anxiety, and depression, because these do have major impact on both the subjective impact of the symptoms on the patient too. So management, you've done a sort of a clinical assessment, you've referred for a 2-week wait endoscopy for red flags. You've addressed lifestyle issues, the patient's failed antacids and alginates, and has had a 4-week course of full dose PPI as per NICE guidelines. Well, then you go along to think about H. pylori testing and treating. You may think about a direct open access endoscopy after that if there's an unclear diagnosis and the patient's unresponsive to PPIs and H. pylori negative.